Finally, I'm able to do what I wanted to do, which is why am I in medicine, right? I wanted to solve problems, right? And now you've actually given me something that enables me to use my mind to solve something that means something, right? Rather than to figure out how to, clerically document the right thing that you wanted for whatever totally meaningless outcome this was, right?
For the 18th time today.
For the 18th time today, I'm instead solving a real problem that affects real people in what I hope is a positive way.
Welcome back to Dear Healthcare, It's You. Welcome back to Dear Healthcare, It's You. I'm here with Dr. Elisha Yaghmai, and I am Joe O'Hanlon. We are continuing to dive into the cracks of the failing American healthcare system. So it's a bleak topic, we know. Last time we were talking about a lot of the bleak parts of it, of the rigmarole that goes into coding and things like that you discovered in Seattle. And ultimately, really insightful episode, actually. If you didn't catch that, please go back and watch it because it's really illuminating for anyone, whether you're medical or not. But ultimately, it left you in a state of burnout.
Yes.
Is where we were going with that.
And before we move to our next topic, I want to throw in one more thing, which I think physicians should relate to, but the public should know about. So one other thing that contributed to the burnout, I mentioned some of the coding dishonesty that goes on, but there was also, there was a second form of dishonesty which went on, which was hiding death. Right. So this was another thing that went on. This is the first time I had seen it was when I went there. It's now, I've seen it in multiple places. So once again, whether they were trailblazers or not, it's now common.
So what does that mean, hiding deaths?
So essentially patients come in hospitals and some of them die, right? I think we all know this, right? Something terrible happens and they die. But what is supposed to happen is there is some measurement of what the death rate is, right? And you would be concerned if a hospital had an unusually high death rate. Or an unusually high death rate for a particular condition, right? And everyone that comes in with something, they die at a higher rate than they do at all the surrounding hospitals, for example. You would question what's going on, right? So and this again goes back to payment, right? It goes back to payment. So one of the strategies that was used in this facility, or this series of facilities, was if a patient came in and it looked like they were going to die, we would switch them over to a different service, effectively a hospice service. And the reason we did that was because if they died on that service, then the death didn't count against the official death statistics for the regular service.
For the hospital.
So it was akin, I think what it was meant to be was if you had a patient, for example, that was on hospice that for some reason had ended up in the hospital or something and they were going to die. So it was a planned death, right? It was like we already knew they had a terminal disease. We've already all agreed we're not doing anything here. We're just hospitalizing them for social reasons, for logistical reasons, for some other thing, right? They need to be hospitalized, but we're not trying to save their life. Like we acknowledge, no one here is trying to save their life. We're just trying to make them comfortable as they pass on, right? That's what that was meant to be for. But at some point, somebody realized what you could do was change your acute care patient to hospice status, even though they came in there intending for you to save their life, right? And then their death doesn't count against your official death statistics. So here again, you're a patient. You're trying to find out how good is my hospital, right? And you look at things like, well, how frequently do people die in that facility? Is it in line with everybody else? Is it out of line? Is it really good? Is it really bad? Sorry, there's no way for you to actually accurately know what the death rate is because those rates are gamed. Now again, when we were doing this in Seattle, that was new to me. Now it's everywhere. It's done here in Kansas and it's done in a variety of other places also. The people may have seen...
It's a standardized practice.
Yeah, it's a pretty standard practice. Certainly in large healthcare centers, it's a standardized practice. You may have seen a news report recently from, I think, Florida or something, where some physicians were alleging that this was done, right, by a corporation that owns hospitals down there. It was denied by their spokesman, but this stuff goes on. And it goes on not infrequently, and it goes on for the reasons that I have just stated. So once again, you can say, well, there's insurance games and there's payment games and things that go on. But the question for the public should still be, don't I want to have an accurate recording of deaths and who's dying and what they're dying from, and if the death rate is either better or worse than what kind of the expected death rate would be? Wouldn't I want to know that? Is that not in my personal interest and in the public's general interest to know? Right? Sorry,
and are these,
it's not.
So these are patients that would not have previously, or in other settings, they would not have had hospice assigned to them.
Correct. Yeah. What would have happened in the past was they would have come in for whatever their condition was, they got sicker and they died, right? And the point of looking at death rate, and here again, people die in hospitals, right? And it doesn't mean anybody did anything wrong, right?
Right.
Nothing wrong may have
They're
been done.
coming there because there's something wrong.
There's something wrong, right? And you're
could go a
trying to
different way.
salvage
Yeah.
the situation, right? But the question you do want to ask from a scientific perspective is, once again, are the people trying to save their life for this particular condition, are they doing an average job, a better than average job, or a worse than average job, right?
Yeah.
And if they're either better or worse, that is a place I would want to investigate to find out, why are your outcomes so bad, or why are your outcomes so good, right?
Right.
There's probably something in there worth learning. But instead, what we've opted for is, let's just make the numbers look good, right? So that once again, we look like we have good death rates. So then again, whatever our payment bonuses or whatever else it is we get, whatever our incentive is to do that is there. And what's lost in that is honesty, truth, accuracy,
Yeah.
right? And ultimately the ability for the public to make an informed decision.
Is it also an additional charge to the patient then to get hospice?
That is an excellent question, actually. I didn't think about that, but you are changing their service, and that may be true, but I'm not gonna swear to that one because I just don't know the dynamics.
Yeah. Dang. Well, and so let's talk about your burnout. Like at the end of the last episode, we were kind of talking about that, and just, it's this mill that just churns through patients and just, works physicians, and I'm sure the other healthcare workers in the facility,
Everybody.
to the bone in a way that's just, it's not sustainable, it's not life-giving, it's not, I would imagine, like, it's not fulfilling your passion that you wanted to get into. And so was it through your notes and noticing those differences that you referenced in the last episode of, like, you were taking notes along your journey about your patient, or not just your patients, but just about your cases and your general demeanor? Was it through those that you started to realize how burnt out you were getting, or how was it apparent to you that you needed a change?
It was in introspection, self-analysis. It was in the realization that that I was coming home angry. So I was working night shifts at that point. I was coming home angry every night, every day rather. When I would come home, I was just angry, and I would, and this is Seattle, so it's heavy traffic, right? So I'd sit there for an hour on the road, commuting back the 10 miles to my house, right? And I would say, okay, I'm angry. Why?
That's what I was just going to ask. Like,
why?
Who did you articulate who you were angry at, or what you were angry at?
I mean, at the time, yes. At the time, I knew the job was making me angry, so I knew that. What I can say in retrospect was, it was running into these persistent conflicts, right? It was this persistent conflict. I mean, what had preceded that? So at that episode, I was working one of the nights, one of the facilities. What they had done at the facility was to save money. Here again, right? There's reimbursements, cutting reimbursements, right? Hospitals are always screaming about this, not necessarily incorrectly, right?
Right.
So to save money, what they had done was they cut the janitorial staff. Here again, you talk about a conflict. They cut the janitorial staff. And you think, oh, it's janitorial staff. Maybe that's not a big deal. It's a huge deal in a hospital, right? So the problem is, here I am, I'm the night guy. I'm being called on all these admissions. I'm trying to take care of these patients. And they're all getting stuck in the emergency room. Why? Because there are no janitors. And because there are no janitors, no rooms can be cleaned.
Yeah.
Right? So the patient ends up stuck down in the emergency room for 12 hours, 16 hours, whatever it is, because there's one house cleaning person trying to go around and turn over every single room, right?
Yeah.
Now, how does that affect the patient? This really happened. My patient is sitting in the emergency room, right? I have accepted them, but I haven't taken over their care yet.
Okay.
They go into shock, right? ER nurse is busy. ER nurse has other patients to care for. And in her mind, the patient has been admitted, so the patient is now gone, right? ER doctor's not paying any attention whatsoever. Why? Because they've got 15 other people that they're also trying to see, right? So
they've checked them off their list.
They've checked them off.
already,
In their
so
mind, they're gone, right? They're not paying any attention to them. Here again, that's not unique to Seattle. That is common. That's common, right? So the patient is now boarding in the emergency room. Nobody exactly is watching, right? So what happened in this particular case was the patient went into shock, right? 2 hours or so into it, I'm like, hey, patient, I don't know what's going on. Let me just check down there. I happen to just log in and check the vital signs and see, oh, wow, we've been recording, shocky blood pressures for a couple of hours now, right? There's been no call to me. There's been no notification to anybody about this, right? So here again, a real harm to the patient caused by the fact that we cut the housekeeping staff, which we did to save money. While that was happening, I think the CEO was being paid $9 million a year, right? And so I go back and I did some math on it, and I was like, we could have paid the CEO like $8.5 million a year and probably kept all the housekeeping staff, but we don't do that here, right?
Which is just backward too, because I mean, just a few episodes ago, you were talking about like how the whole system is predicated on needing the hospital to be full to work, like to work how it, in this broken system. But
so you got a bed, right?
Yeah.
Don't have a housekeeper, right? You cut them to save money, but at the same time, we are paying an enormous amount of money, right, to the putative leader of the organization, while the organization is failing in its mission. Does that make sense?
Yeah.
Right? It's failing in its fundamental mission, which is to keep the patient safe.
It sounds like it's adding a very heavy load of stress to the physicians too, because you're doing the extra work of keeping in your mind that you have this patient that you can't see, that's not on your floor yet, that you just got told that is coming. And, when you're overworked, would be easy to just put them out of your mind until then. And you're doing the due diligence as you remember or as you can to look at them, and then finding out that they've been just pushed off to the side and are in shock for 2 hours. Like, I mean, that's just an increased stress load on your already overworked and misdirected whole schematic at that point. Like, so what did did you want to quit medicine?
Not yet, not at that point. I just wanted to change. I thought at the time I wanted to just change settings, right? So I sat down, I went home after, several of these, and I sat down and I thought, I'm either going to lose my mind doing this, or I'm going to have to lose my soul. I can't keep both. I can't keep both of these things, because they're just the conflicts, the perpetual conflict between what I believe is right and my obligation to the patient, right?
Yeah.
And that's the thing, like a lot of physicians actually take that seriously, right? It's not just the oath, it's like people come in and they entrust you with their life, right?
Right.
It's like the most valuable thing they have.
Yeah.
And so you're trying to, if you take that responsibility seriously, right? Because the trade-off society has made with physicians, right, is that we're going to give you some social respect for whatever that's worth. We're going to pay you a lot of money, right? And the trade-off is you're the stewards of our lives. Like, that's a really serious obligation.
Yeah.
Not everybody in medicine takes it seriously by any means, but it is a real obligation. It's a serious obligation. So you have this constant conflict between your sense of that obligation and then all this other madness that you see going on, which is just chaos. It's usually not at all centered around what's good for the patient, right? It's just, it's got a lot of other incentives, but the patient's good is not one of them, right? So your choice in that situation is you can either go along with it and become apathetic, or you find a way to leave, right?
Become apathetic and probably have your level of care that you're providing would have to just decrease.
It goes down.
To stay there.
It goes down. Yeah, it does. No, it very much does. And you see it. You see it. You see people make the concession. They say, I cannot do this anymore, so I'm just going to deal. I'm just going to do what I can do, right?
Yeah.
Within the constraints of this system, all these tools you've given me, they're just garbage tools. They're worthless. They don't make my work any better. I'm just going to do what I can do. And when I hit the limit of what I can do, that's where I stop. Right? And whatever happens after that, it's not my problem. Right?
Yeah.
And the doctors that don't adopt that either leave,
right,
or to some degree just kind of lose their minds. That's the best way I can describe it, because there's not a way to resolve that tension constructively.
Well, and I mean, through COVID, we've seen just droves of people leaving the healthcare field because it's been just even exacerbated more so. But so you were feeling like it was more that it was that sort of a high profile center that had so much traffic and so much opportunity to get burnout in the ways that you were, that you were thinking maybe a different environment would solve that?
Yes.
And so what was the environment that you had hoped would do that? My initial intent, I mentioned a few episodes ago, when I initially got into medicine, I thought I was going to do international medicine, right? So I was going to go overseas and I was going to work in a developing country, right? This kind of thing. So that was my thought was, let me just go somewhere. This is the fantasy all doctors have. Let me just go somewhere where they just let me do medicine, right? Like I could just focus on trying to be a good physician, right? Focus on the science and the outcomes and these kinds of things. So I thought, okay, maybe internationally I can do this, right? So I tried a variety of different things. I tried to get in touch with people. I think at one point I tracked down, at that time there were probably, 40 doctors in Liberia or something, right? I tried to find an email on the internet, and just send a cold email. I never got a response to that.
I tried things like that. I tried to go through organizations in certain situations, and just none of it worked out, right?
Yeah.
For various reasons, none of it worked out. So then I thought, okay, well, what's the closest we get to international work in the United States? Well, rural. I thought rural healthcare, right? There's always shortages, right?
Yeah.
So maybe rural healthcare is where I should go to find a place where I'm going to be able to practice in the way that I feel is appropriate.
Yeah.
And maybe the rural hospitals don't have the same imperatives that the urban hospitals have. That was not correct, right? But this is what I was thinking.
I was going to say, we've heard already, that's not been your
Yeah.
case, but
Right.
at the time you didn't have that knowledge.
I didn't know that, right? So this is kind of what I thought. So I thought, okay, I'm going to do that. And then the thought process from there was relatively simple. I knew that at that time I had a child, right? My son was 3 or 4 years old.
Yeah.
And I was like, I can't just go, and my wife was still in fellowship, right? So she's working like crazy, right? And I'm like, I can't just go flying around all over the place, right? And just sort of leave my son here. What am I going to do?
And she's in the midst of the fellowship,
And she's in the midst
so
of
it
fellowship,
wasn't an option to
there's
relocate.
not an option, right? So I was like, what to do? And I thought, well, okay, I'd seen a little bit of kind of virtual care going on, video conferencing type stuff. And I thought, well, maybe we could use this as a solution to the problems in rural health, right? And I kind of, here again, a few episodes back, we talked about, kind of the locum tenens system, right? Bringing in temporary doctors, right? And you're paying a company, $300 an hour or $400, whatever, some enormous number, right? To bring a doctor in. This is how rural healthcare has done staffing for decades, right?
Yeah.
So you try to hire and get someone into your community, right? Or multiple people in.
Right.
But if you're not successful at doing that, you have holes in your schedule. And to get things covered, you go to a locum tenens company and they charge you a premium to try to find you people that they slot in for however long that is, right?
Yeah.
And the problem with that long term is that the prices are very high, right? And the volume of patients in many rural communities is so low that it's not financially sustainable long term.
Right.
This is the problem, right?
Yeah.
And so at that time, we already had dozens of rural hospitals that had already gone bankrupt, right? And there were
closing their doors.
Yeah, they were just shutting down, right? And so then what would happen is the community would lose its hospital, depending on the size of the community. Sometimes that meant people could be going 100 miles, 80 miles, whatever it was, to find the next hospital, right?
Wow.
So you look at that situation and say, okay, well, what are we going to do about this, right? And so my thought was, wait a minute, why don't I use this virtual stuff and I can figure out how to cover a hospital.
You had seen it being used somewhere? Or
I did. Yeah, we used a tiny bit of it actually in Seattle. We used a little bit of it. They had big carts, right, and this kind of thing. And so we'd done a little bit of it. And at the time I did a few cases that way, and I was like, it's okay. It's not too bad.
Yeah.
But I had pretty limited experience with it.
So you guys were using it there in terms of treating people that were elsewhere?
At a different campus, a different campus in the system, right? So I'd seen enough of it to know it was a thing.
Yeah.
Right, but it wasn't very developed and it wasn't very heavily used at that time, right?
And the way that you're speaking about it, just to clarify for our audience, it's not like we experience now of like talk to your doc on the phone for a regular appointment. This would be for like hospital visits.
That's right. Yeah. This would be a hospital. You're in the hospital, right? And you, instead of having a doctor walk into your room, right, you're instead seeing them on a computer screen, right? And they're communicating with you over the internet and then putting in orders.
So you still would go to the facility that you're used to going to, but they wouldn't need to have a locum tenens. Is that what the word?
Yeah, rather than having a locum tenens physician, right?
Fly in
they would
when
instead,
someone's gone, then they would just be able to see you over the internet.
That's correct. Yeah.
Okay.
This was how this worked.
And you still have the nurses and everything, the normal staffing, normal testing available.
All that stuff is the same. Yeah.
Okay.
So all that happens in this kind of theoretical system that I came up with in my head was we're just saving them a bunch of money, right, on the price of staffing. And the logic was very simple. A lot of the smaller rural hospitals, they've got 1 or 2 inpatients, right? I mean, bear in mind, right, in my normal day, I'm doing probably 15, 16 very complicated patients, right? These are 1 or 2 patients, often not as complicated. That's why they're in the small hospital and not the bigger one, right?
Right.
So I was like, hey, look, I could do, if they all have an average of 1 patient a day, right? I cover 10 of these places simultaneously. It's still not a full day for me.
Right.
I charge everybody 1/10 of the price of the normal service or my normal service, right?
Yeah.
So they get a 90% discount, right?
Okay.
And then I can be, because it's virtual, and I don't have to travel, I don't have to fly or drive there, right? I can be readily available like all the time, right? Because I just sit where I'm sitting and I just beam in on the internet when I need to see a patient.
Yeah.
So that was the basic idea, right? And I was like, this makes sense. It's simple. It's easy, right? Seems like it solves the problem. And then the other piece that solved, there was a but. The other piece that solved, though, was the quality issue, right? Because using virtual care, my logic was the problem that rural communities have, besides the price, right, is that, look, I mean, how many people in the country are like, you know what I want to do? Like, I want to go out to a far rural town that's 4 hours from the nearest city, right? That's what I want. That's where I want to spend my time. It's not that many people, right?
For doctors,
For doctors, right? Yeah. And then how many on top of that are like, you know what? Oh, you need this, in 2 weeks, right? Oh, I'm available. Let me do that right now, right? I mean, it's a tiny number of people.
Right.
So what that leads to is variations in quality, right?
Yeah.
You may get a great doctor. You may get a really bad one, right?
Yeah.
You have no means to know this. But what you can do with virtual is you get extended context because, again, you take the travel out, right?
Yeah.
So the same doctors, one can be available. So you begin to understand who you have. And you can recruit much more broadly because now I don't care where the doctor is, right? And they don't need to travel, so I can recruit from anywhere in the country. So in theory, at least, I should be able to bring in higher caliber physicians who can be consistently available to a small community for a tiny fraction of the total price.
Right. Were you thinking of like building a locum tenens alternative, or like going through that system and being staffed like through those same agencies?
It was meant to, no, it was meant to be an alternative. It was like, hey, you don't need to pay these people $300 an hour anymore.
Yeah.
Right?
But it would take each of those hospitals that you were serving having the technology
correct.
in place.
That was the original barrier, right? It was the technology. Because at that time, video conferencing was obviously already a thing, right?
Yeah.
But at that time, the way it was done.
What year are we in here?
This is now 2014.
Oh, okay.
Yeah. So there's, it's there. Right?
Yeah.
People are somewhat familiar with it at least.
Skype at the least.
Yeah, Skype was being used,
Yeah.
right? You could do. I think there was some iPhone, iPad stuff, right?
Yeah,
You could
I think
FaceTime
so,
or whatever. These kinds of things were in some use. But in healthcare, the way this was most commonly done was by a company called Polycom, right?
Okay.
And you had to put these Polycom terminals on each side. At the time, they were about $150,000.
Wow. Okay.
Like per one.
Yeah.
So you had to put that on both sides of whatever the equation was, right? The doctor and then the patient side. They were large and they were fixed. So you'd put it in a room, for example, right? But it wasn't like it rolled around or something, right? So if you wanted something that would roll around, there was a so-called robot, which is basically a computer on wheels. It wasn't really a robot.
Okay.
At the time, made by a different company. That was pricing out. If you wanted one that would run by itself, it was about $60,000. I think if you wanted one that you would push around, it was about a 110-pound cart, if I recall correctly, in that neighborhood.
Yeah.
It was like $35,000, $40,000, something in that range.
Okay.
And then if you wanted to go to kind of the bare minimum cart,
Yeah.
it's about $25,000
Okay.
right, to push one of these carts. So you had to push it all around. Again, all of these are just computers on wheels for the most part.
Right.
And then on top of that, if you wanted to actually do an exam, like if you wanted to do a heart exam, like listen to their heart or look in their ears, these were extra attachments, right, which were costing at the time like $3,000 to $5,000 each, right?
Okay.
So to realistically set this up, right, you needed a couple $100,000.
Yeah.
Bare minimum, you probably need $25,000, $30,000, right, to do this. So the first problem when I kind of began to broach this idea with the rural communities was, how do we afford it?
Yeah.
Right? Yeah, interesting idea. We're interested in exploring it further, but how would we afford it?
Was it not going to save them enough in terms of
they weren't
other
even
side of things?
This was so long ago in technological terms, not in life terms, that for one, many people didn't even understand what I was talking about.
Oh, interesting.
I would talk to them about it for an hour, and
they couldn't wrap their mind around it.
They couldn't wrap their mind because the idea that you didn't have to have a physician walk into a room to examine and see a patient was like just not commonly known, right?
I mean, until like 2020.
Yeah, exactly.
Really? I mean,
that's when it became much more commonly known, right?
Yeah.
So this was kind of the scenario. So one was just getting people to even comprehend that this was possible, right? We didn't even get to what are you going to save on this versus the cost of the equipment.
They just saw it as this huge,
They saw it like
obstacle.
This is some weird new thing, and then you want me to spend a whole bunch of money, right, on this stuff, and I don't have it. I don't have this cash around, right? And half these hospitals were struggling in the first place, right? That was part of the issue. So, so what I did was I went back and said, well, okay, I mean, if I can like FaceTime on an iPad or Skype or whatever, why do we need the $25,000 cart?
Right.
And it didn't make obvious sense. So I was like, well, let's try to use an iPad and or
That
a
was
computer.
sufficient for what you would need it
To
do?
interview the patient, it was,
Yeah.
right? And then at the time, there were these stethoscopes that a company called Littman made. They make regular stethoscopes.
Okay.
At the time, I think were about $750, and you had to buy 2 of them to get the connection to work. So you could examine their heart.
Yeah.
You could do that, right? So that was the initial model.
Is
was
that
just
the
these 2
same
things.
stethoscope that was used at with the packaging that you had experienced in Seattle?
I can't remember if it was Littman or not. It might have been. It might have actually been. Yeah, I think it was similar. So the biggest variation was let's just use an iPad rather than all this $25,000 stuff, right?
Right.
And then pair it with a stethoscope, and and there were rules. You had to use a computer with the stethoscope. So it was like, okay, we'll need to have a computer nearby, but we can make this
Okay.
work, right? So it was kind of clunky, but it was like
Yeah.
it would do the job in a clunky form.
Yeah.
Right. So then, so that was kind of step 1. So then step 2 was actually I recruited in the second guy who was another physician, right, to look at this, right, and he began to look at the technology and came up with another solution,
Okay.
which was again pre-made, right, that you could plug into the iPad.
Another stethoscope?
There's different stethoscopes
Oh,
that you could plug into the iPad. So you solved the clunkiness problem by finding. And the thing about it was, here again, this technology was all out there.
Yeah.
It's all stuff that
You
already
just weren't
existed,
needing to
right?
piece it
You just needed to
together
piece it
to-
together. So in the end,
And nobody else was using it like that yet.
if they were
not to your knowledge.
Yeah, not to our knowledge. I'll put it that way.
Okay.
Because almost nobody was even trying to do this, right?
Yeah,
This is
yeah.
the thing. Like no one. It wasn't that somebody couldn't have thought of this. It was that no one was trying to do this, right?
Right.
There just wasn't a demand.
So then how did you proceed from there to get doctors and doctors to
Yeah.
perform this remote stuff and then the hospitals to actually agree to it? How did that go?
So it was a lengthy process. The recruiting of physicians was actually very easy. So they're kind of going back to what we discussed before, right?
Yeah.
I wasn't the only person feeling that sort of
Burnout stuff.
burnout and angst, right? So when I went to just physicians that I met over the years, right, and
Yeah.
said, "Hey, you want to help me with this project?" The answer was almost always yes.
Really?
Like an enthusiastic yes. Yeah, people loved it. They were like, "Absolutely, I want to help rural areas." And by this time, I knew Kansas because I'd been there before, so I thought rural Kansas is as rural as it gets, right?
Yeah.
So let me take this back to Kansas. I know the ground. I kind of know how things work there, and people were absolutely on board with it. So that was the initial concept that we had tried to roll out. A bunch of docs were on board with that. While we were doing that, also different subspecialty docs had also expressed interest in this. So people that did mental health, dermatology, various other things, right? They were also interested in doing this. So then what happened was a series of reaching out to hospitals, making contact, and I was flying back to Kansas twice a month at that point. So I was flying from Seattle back there. I was driving all over the state, right?
Because you were focusing here.
Yeah, I was focused on
just
Kansas.
because you had familiarity with the
I knew the place, and Kansas was very rural. Kansas also had at that time the most critical access. Critical access hospitals are hospitals with less than 25 beds. They're paid a little differently than regular hospitals.
Okay.
But generally speaking, critical access is kind of code for small rural hospitals.
Yeah.
That's not universally true, but it's often true.
Yeah.
So I thought, who better, right? Critical access hospitals are often in small communities. They're often struggling for staffing. They're often struggling to make money, right? They're under stress, right?
Yeah.
And a lot of them are closing. So I thought, and Kansas has a bunch of them, so great place to
Right.
start.
And you were already licensed in the
And
state?
I was still licensed in Kansas. I'd kept my license from before,
Okay.
so it was very easy from
Yeah.
that perspective. So I went around. So I flew in, I would drive all over the place, right? Go through that process, and I would sit down and pitch these hospital CEOs about what we were doing. Started bringing tech demos with me, as we do this. So all this is
So
going
you're
on.
a travel salesman.
Yes, I am doing travel sales. That's exactly what's going on. And the hook on this is that there were 2 things. So one was recruiting all these doctors, putting the structure together, getting everybody licensed in the state of Kansas, getting everybody credentialed with these hospitals. Right, there's a bunch of back end paperwork again that goes into this. So we did all that. The second ingredient of that was the technology piece, which I mentioned, right? So by this time we had some third-party software, an iPad, also third-party, and a stethoscope, also third-party.
How much did all that end up being?
I want to say it was about $1,300.
Okay.
So we had
super affordable.
Yes.
Yeah.
The price had dropped from
Compared to 35,000 or whatever.
25, 35, 60, 150, right, to $1,300.
Yeah.
So, kind of a story I've told before in other contexts was, I can't sort of overemphasize how significant that was, right? Because we initially had thought, we're working with the usual equipment. And then we went down that consumer electronic route, and the other doc that I brought in put a lot of time into this.
Yeah.
And aside to that, and I'll get back to that, but he put a lot of work into trying to find these pieces, right, to
get
plug
the
in,
tech
to get everything
solution figured out.
properly done, right? So because at one point I remember he'd ask, hey, you also do pediatrics, right? Do you need to look in ears? And I was like, yeah, ideally I would like to look in the ear, right? How are we going to do that? So here again, he found an attachment that you could put on an iPhone, right? You could look in somebody's ear.
Okay.
So, but the point of it was all this technology comes together. And the first time we realized it worked, we sat there and said, wow, like we have solved access to care.
Yeah, I was going to say that's a huge breakthrough.
Yes, we were like, we can interview the patient. We can listen to their heart and lungs. We can look in their ears or their throat or their nose or whatever. We have the ability to do all of this using third-party consumer electronics, right?
Yeah.
So we're like, we have access to care is now solved. You can see a doctor anywhere in the world that you want, that as long as they've got a cell signal, right? We can do this.
Which is
right?
huge for underserved communities.
It's a massive thing,
yeah.
right? So we thought
that you were the saviors of healthcare.
we thought, here again, the analogy I'll give is, it was kind of like George Bush on the battleship, where we thought we'd be greeted as liberators, right? Okay.
It's a hard moment.
Right. And so what we did was we went around and we were like, look, rural communities, we will pay for the technology, we'll give it to you.
So you're just trying to sell them on the concept of
just let us provide care. Let us relieve you. Let us provide care in your community.
Yeah.
We will give you the technology for free. We'll pay for it out of our own pocket.
And how many agreed to that?
Initially, over time, over the first 2 years, it was about 30 communities, I think.
That's
33, yeah, agreed to do this, right? So lots of travel and work go into this, all kinds of time. So we kind of set all that up, started rolling out the technology, and then we ran into, kind of as all that was going on, the realities of sort of how healthcare actually works, right? So
it's back to insurance.
It's back to insurance, right? This is where this goes. And so, the first issue that we ran into was Medicare had set up a rule where this was from years before. The telemedicine physician could not be the admitting physician. They could not be the admitting or attending physician. Basically, they couldn't be the person with primary responsibility. This was buried in the Medicare manual. So there's one line in the Medicare manual. So if you don't know what to do about a case, you can call somebody and they can suggest to you what you would do, right? But they're not going to step in. They're not going to take over the case and do any of these things that you might need, which is the opposite of what we had proposed to do, exactly those things.
Right.
So we find out that Medicare has this rule where they won't allow us to do this. So we then said, all right, well, if we can't do that right now, then we'll start with just offering subspecialties because we also have these, right?
Yeah.
And so our first subspecialty we rolled out actually was endocrinology with a doctor from here in Wichita, right, who did that and started seeing patients, right? And just began to gain just a little bit of traction, showing, okay, this can actually be done, or it can be done properly on this very limited ambulatory outpatient care model,
right?
While we continue to go around and try to work with insurance and the regulations, and then find somebody to allow us to trial the kind of hospitalist thing, which we ended up getting over time.
You did get something?
We did. It took a long time.
It
took maybe another year or something like that before we were actually given the opportunity to launch it, right?
And then it was being covered by Medicare at that point? No,
it wasn't actually. Okay. So then what we did was we figured out a workaround. The workaround was the local physician, when an admission would come in, the local physician would consult us, right? And so we would consult as the consultant, and this is true anywhere you go. As a consultant, we had the ability to do anything. We could write orders, do whatever. So as a consultant, we would come in and effectively we would admit the patient.
Okay.
We would do all the work. We would interview them. In the morning, they would come back in and readmit the patient. They would see them, right, and do this. Obviously, this is, here again, right, a redundant, wasteful, silly system. Right?
But it still did allow them to not have to be there the first time.
It did, but at least it accomplished the basic goal of getting some rest, right, while we cover the place.
Yeah.
But because of the silliness and redundancy in it, right, again, it was a tough sell, right, because people are like, well, I already have somebody here, so why wouldn't I just have them do whatever they do? So initially, actually, when we started off, we did it for free. Actually, I did the vast majority of it, right?
Really?
Yeah, for free. So I would just be on and I would take calls all night and I would do whatever I was doing and try to see the patients and just be like, we're just going to donate our time. One of the other docs, I think, was working initially at a pretty reduced rate.
Okay.
right, for his. But it was a lot of free work, and it was a lot of just spending saved money,
Yeah.
personal savings, right, to try to get these things launched and going. The whole time, though, the rationale for it wasn't just martyrdom, right? The idea was, hey, this will work, right? And so all we got to do is show proof of concept. That was
You're
where
trying
we
to
were.
bide time
We're
until
like,
that went
let's
through.
just show proof of concept. Let's show that this works. And then when we show that this is a better way to do rural healthcare, it's more cost effective, it's higher quality, it's more sustainable, et cetera, then surely, right, all the gates will open.
Right.
And and then we'll be able to finally do what we want to do.
Yeah.
And that was wrong. That was totally, totally wrong.
Which, how do you keep being so optimistic in the face of you have two sides of yourself where you're very jaded. You're willing to create an entirely new system, and yet you continue to be like, they'll figure it out. Like, they'll see this, they'll believe in it at some point. Like, I mean, do you have an answer for that? I mean, that's an interesting piece of you too.
Yeah, it's so I think two things were going on, right? One is, remember we talked about working on the wrong things, right? So this was an opportunity, just personally speaking, this was an opportunity to work on a project that I felt was meaningful. I thought it could make a positive impact on the lives of a lot of people, right? And I thought it was just a matter, we just have to, okay, first we have to solve the technology, then we got to figure out the logistics, and then we got to figure out the licensure and the credentialing, and we got to do, right? And we're doing all these things, and all that work, some of it busy work, some of it real, required a different kind of thinking than medicine and some creativity, right? And working on problems. Interestingly enough, actually, my colleague that was working with me, there was a process which I still to this day call intellectual reconstitution syndrome. Like this, so there's something called immune reconstitution syndrome. This is when somebody has HIV, their immune system gets really knocked down when the HIV is out of control. When you control the HIV, their immune system kind of comes back. It comes back and has a lot of effects which sometimes can be negative on the body. Let's spare you the technical jargon. The point was, it was kind of intellectual reconstitution syndrome. What I mean by this is that I watched his process as he got involved and began to research these things and began to get engaged again in solving a problem, right? That he felt was meaningful.
Yeah.
It was really fascinating to watch his mind switch back on, is the best way I can describe it, right? And I observed the same process with myself, right? I was like, okay, finally, I'm able to do what I wanted to do, which is, why am I in medicine, right? I wanted to solve problems, right? And now you've actually given me something that enables me to use my mind to solve something that means something, right? Rather than to figure out how to, clerically document the right thing that you wanted for whatever totally meaningless outcome this was, right?
For the 18th time today.
For the 18th time today, I'm instead solving a real problem that affects real people in what I hope is a positive way.
Yeah.
Right? So that's where a lot of the initial optimism came from, because it's like, finally, I am able to do something that I feel has some kind of value. Right? And that attitude, that optimism is really what spread through. So on the one hand, there's a cynicism. On the other hand, the other thing is, it's like you have hope, right?
Right. You saw a glimpse of a solution.
Yes.
With that, like, I'm sure it must have felt like a clouds opening moment of like, maybe medicine can get better.
Yes. We can solve this rural health conundrum, right? That's existed and has been getting worse and worse and worse for decades. Like, we can fix this.
Yeah.
We can fix this. And so that initial optimism is what floated us through a lot of those early periods.
Yeah.
Right?
Which I'm sure we'll talk more in depth about some of the struggle of that at some point. But you mentioned with Medicare, that there was the problem and then the workaround and then eventually getting solved. But what about on the private side of healthcare?
The private side
for health insurance
was so much worse. It was so much worse. Medicare, I would describe they were bureaucratic but not malignant. Private insurance was much more malignant in their approach. So there we went through this very lengthy process, which we can probably detail more next time, but a lengthy process of like an ongoing battle for years, trying to get recognized. First of all, trying to get conversation, being rejected.
Like not even being able to get a seat at the table to talk about it.
No ability to discuss, no ability to do anything, despite the fact that we were checking all of the alleged boxes that we were supposed to meet to do this, right? And even after they rolled out some additional checkboxes, so they added some requirements that weren't in their written publications.
Gotcha.
Right? All this stuff kept going. So So that is when I think the kind of the bloom began to come off, right? Because we're like, okay, we solved all the other issues to some degree. It wasn't all perfect, but it was good enough to do the job.
Right.
We've solved all these
just
things.
Stonewalled by.
And then here we are, right? The people that really control this
Yeah.
are not interested in having us do it. And
Or
so
even the conversation.
Or the conversation about it, and we are stymied. We can't do anything.
Gotcha. Well, that definitely puts a damper on the plans, I would imagine, because you can't really run a healthcare business just footing the bill for years.
Yes.
So, well, we'll pick up with that. I know that there is more to that story. I'm curious to hear from you all the details of that battle with insurance, but ultimately, I mean, it's a thread that's run through our whole story this far, is insurance being such a factor, the billing being such a factor, but insurance especially tied in, not that they're the villain in the story necessarily, but it's just one of those arms of this dilemma in healthcare of that if insurance won't pay for it, then we're not doing it, sort of thing. So we'll pick up there next time. Thanks, Elisha.
Thanks.